So the last and distal portion of the gastrointestinal tract is going to be the large intestine. The large intestine, as we see on here, it's going to be receiving the undigested and absorbed part of the food through the ileum. And we can notice on here this pouch-like structure that will be receiving this undigested part of the food. It's going to be the cecum. And in order for me to allow a unidirectional movement of the feces from the ileum to the cecum, there will be a valve located in between. We call this valve is the ileocecal valve. Next part of the large intestine is going to be the colon. The colon has an ascending part, a transverse part that travels horizontally like this, and then the descending part that travels downwards. So the colon is divided into ascending colon, transverse colon, and the descending colon. Then I have this flipped part that looks like an S-shaped portion of the colon. This is going to be the sigmoid colon. Straight part of the large intestines, this is what we call the rectum. And the rectum is going to be conducting the feces to the anal canal that will be guarded by the external anal sphincter. So again, what are the main components here of the large intestine? We've got this pouch-like structure that receives the feces from the ileum. This is the cecum. What maintains the unidirectional movement of the feces from the ileum to the cecum is the presence of the ileocecal valve. We've got the colon here, has ascending part, transverse part, descending, and this S-shaped part is going to be the sigmoid colon. Sigmoid colon, because of its structure, it's the most common site for the development of constipation because it's going to be taking a person much greater effort to move the stools through this S-shaped portion. So the stool's gonna remain for longer time within the large intestine, causing more absorption of the water and hardening of the stools. All right, so for our first in-class activity for today's session, what are the digestive processes that are taking place in the small intestine? Do we have any chemical digestion? Can you remind me? Do we have any chemical digestion within the small intestine? Yes, no. Yes, what is actually performing chemical digestion in the small intestine? Remember, bile, pancreatic juice, and the brush border enzymes. Do I have any absorption taking place in the small intestine? Yes, most of the absorption is taking place in the small intestine. Absorption of the fat, carbs, proteins, nucleic acids, all those are going to be taking place in the small intestine. Do you have any propulsion in the small intestine? Yes, we have the two types of propulsion, peristalsis and segmentation. So what's the good answer on here is all of the above. A, B, and C all are taking place in the small intestine. Moving on to the straight part of the large intestine, this is going to be the rectum, and the rectum contains three rectal valves. This is how they look like. And those valves are necessary to allow the gases to travel out while retaining the hard stools inside. So the gases will be able to travel out while the rectal valves are holding the stools from passing with the gases. The anal canal is the last segment of the large intestine. It has two sphincters, an internal anal sphincter, which is under involuntary control. It's full of smooth muscles compared to the external anal sphincter, it's under voluntary control. It's going to be formed by skeletal muscles. The defecation is very similar to the micturition. Defecation is very similar to the micturition. So how defecation takes place? Got the mass movement here of the stools will cause the stretch of the rectum. And in the wall of the rectum, we've got the receptors detecting the degree of stretch. This will send out the signals to the central nervous system, and through the parasympathetic nervous system, you're going to be sending out the signals to the rectum for it to contract. All this is under involuntary control. At the same time, the parasympathetic nervous system is going to be dilating the internal anal sphincter. Remember, the internal sphincters have a radiating appearance on here, like this. So they are, while they are relaxed, they are closed. And when you send them the signals through the parasympathetic nervous system, they will be performing the contraction, and as a result, they open. So they open by contracting. This is for the internal anal sphincter. Now the person will feel the urge to defecate. How do you control the movement of the stools out through the anal canal? You're going to be contracting the external anal sphincter. This is under voluntary control. When it's suitable, what you're going to do, you're going to be relaxing the external anal sphincter, and this will allow the movement of the stools through the anus to the outside. So defecation, we've got a voluntary part and then involuntary part. The involuntary part is going to be the contraction of the rectum, allowing the movement of the stools down towards the anal canal. The other effect It's going to be the contraction of the internal anal sphincter, allowing it to open. The voluntary part that you're going to be performing, it's the contraction of the external anal sphincter. To hold, when it's suitable, what you're going to do is you relax the external anal sphincter, opening the anal canal to allow the stools to move to the outside and defecation to take place. It's very, very similar to what we discussed back with the micturition. What are the different functions of the large intestine? The very first important function of the large intestine is to allow absorption to take place. In the large intestine, we are performing absorption of important vitamins, water, and electrolytes. Why do I wait all this time until I get to the large intestine for me to absorb those vitamins? Why you didn't absorb those vitamins in the small intestine? Why did you wait until you get to the large intestine to get them absorbed? Because simply you didn't have them in the small intestine. Many of those vitamins, like the B vitamins and vitamin K, are going to be produced by the bacteria living in your large intestine. So the bacteria flora living in the large intestine going to be breaking down the undigested part of the food, and through their metabolic activities, they will be releasing those vitamins, which will make them available for you to absorb in the large intestine. So you didn't have those vitamins back in the small intestine for you to be able to get them absorbed. You just got them by the bacteria flora living in your large intestine. Another function of the large intestine is going to be the propulsion. And the major part of the propulsion is to allow the propulsion of the feces to move towards the anus. And the third function of the large intestine is to allow the defecation to take place, the release of the waste to the outside. Colon is not essential for life. So a person can perform colostomy, he can remove a large part of his large intestine. If a person, for example, has pre-malignant lesions or he got some kind of cancer in the large intestine, so he can remove large parts of the large intestine and he still can survive. It's not essential for life. So you will see in the hospital, for example, some people who got the large intestine removed, they have a pouch or a bag pending down from their abdomen. This is where they will be accumulating the feces. Did anybody see this before? The colostomy patients where they have a bag pending down from their abdomen? Yes. So why do they have this bag? Simply because they have removed large parts of the large intestine. Moving on to homeostatic imbalances, and the most common homeostatic imbalance that is related to the gastrointestinal system is going to be the gastroesophageal reflux disease. If you remember, the esophagus was lined with stratified squamous epithelium. Remember, this is a protective type of epithelium, and it was non-keratinized. Compared to the stomach was lined with one row of columnar cells, which allowed the stomach to form a thick mucus covering, preventing the digestion of the wall. If you remember, inside the stomach, we've got hydrochloric acid, we've got the pepsin, which is the digestive enzyme that breaks down the protein. So if the gastric acid did travel up into the lower esophagus, the stratified squamous epithelium doesn't produce mucus. So I don't have this mucus layer covering my epithelium. So what's going to happen? This might result in irritation of the mucosal lining of the lower esophagus. And if it didn't get treated, this can turn malignant. It can cause an esophageal carcinoma. So it can cause inflammation of the esophagus, esophagitis, ulcers, and can turn into an esophageal cancer if it didn't get treated. What if a person did take aspirin? Why do we usually ask patients to not take aspirin unless they eat? For the aspirin to not be in direct contact with the epithelial lining. Why? Because one of the functions of the aspirin, it prevents the mucus formation. So if I prevented the mucus formation, what's going to happen? Now the epithelium lining the wall of the stomach from inside is going to be in direct exposure with the hydrochloric acid and the pepsin. So the wall of the stomach will be irritated, inflamed, causing the development of stomach inflammation or what we call a gastritis. One of the most common reasons for peptic ulcer, it's a bacteria that has the ability to survive by embedding itself within the mucus covering of the stomach. This is what we call the H. pylori, Helicobacter pylori. The Helicobacter pylori encapsulates itself by a capsule of chemicals that inhibit the mucus formation within the area where it's located. And as I get an inhibition of the mucus formation within the infected regions of the stomach, those infected regions by the H. pylori gonna get exposed to the digestive enzymes and the hydrochloric acid. And as you see here, this might result in developing of a gastric ulcer. The wall itself might actually become perforated. So think of it like if I can digest this thick burger patty, I can simply digest the wall of the stomach as well. Right? What protects the wall of the stomach is excuse me, is the presence of the mucosal lining. The mucus, thick mucus lining, the inside of the stomach is what gives it its protection from being digested by the digestive enzymes and the hydrochloric acid. Moving on to homeostatic imbalance that will affect the liver. Inflammation of the liver is what we call hepatitis. Hepatitis is more common in men than in women. Usually it is caused by the hepatitis viruses. Hepatitis A causes an acute hepatitis, acute inflammation of the liver. So a person will develop jaundice within days, pain, fever, and then will be able to overcome the infection and it's going to be fine. Or if it gets so bad, it can cause the destruction of the whole liver parenchyma, causing major destruction of the liver, and a person might actually die. But this is very rare. So this is what we call acute hepatitis. On the other hand, hepatitis B and hepatitis C viruses, those usually are causing chronic inflammation. So they will live in the liver, they will keep infecting the liver cells over years. And the person will not notice major symptoms of the disease until most of the liver is gone. Most of the liver is already destroyed. So it doesn't represent itself by symptoms early in the disease, but rather late in the disease. But other less common hepatitis viruses like hepatitis D virus, which can't actually infect the liver on its own. It needs to infect a liver who is already infected with hepatitis B. Liver cirrhosis is due to a progressive chronic inflammation of the liver that might be due to a viral infection. And in this case, it's going to be either hepatitis B or hepatitis C virus infection. Or it might be due to chronic exposure to alcohol, so alcoholism. What is the problem with the liver cirrhosis? I've lost the normal architecture of the liver. Liver cells are not permanent cells, so they can regenerate. But the problem here is that as they regenerate, they destroy the normal structure of the liver, making it so hard for the liver to perform its normal activities. Also, this is going to cause fibrosis and accumulation of fat within the liver because this is a fatty fibrosis of the liver. Two of the most common types of cancer that will affect the digestive system, those are the stomach and colon cancers. The problem with those two types of cancer is that they rarely have early signs or symptoms. So a person will not figure out he got a colon cancer or a stomach cancer until very late in the disease, even after sending metastasis to other organs. So patients will not recognize they have got actually a colon cancer until, for example, they got a destruction of the liver by the metastatic cancerous cells that actually did leave the colon and metastasize the liver. Prevention is very important in those cases, and prevention is going to be taken place by performing regular medical examination. And the type of examination that we usually recommend here, it's for the colon cancer, is to perform a colon endoscopy. So any person with family history of colon carcinoma after the age of 40, he needs to perform a lower endoscopy. Any person, any male after the age of 50 will need to perform an endoscopy to check for any pre-malignant lesions in the colon. Any questions? Questions? All right. So this